Thank you, dignitaries, for conducting an informative symposium. And next, we will move towards the Symposium 3 on the topic Medical Research and Innovations in Patient-Centered Care. I would like to invite Dr. V. Sujanita, Head and Senior Lecturer, Department of Medicine, Faculty of Medicine, University of Jaffna, and Dr. Ramya Kumar, Senior Lecturer, Department of Community and Family Medicine, Faculty of Medicine, University of Jaffna, to chair this symposium.
Good afternoon. I warmly welcome you all for the Symposium 3 of today's sessions. In the interest of time, I think we will move on to the symposium directly. So the topic is on medical research and innovations in patient-centered care. We have 3 presentations today, and which one will be a recorded presentation. So the first one will be by Dr. Saumya Shekhar who will be talking on unlocking the future through genome sequencing and diagnosing. This will be a recorded presentation. So a few words about Dr. Saumya Jamwar. He is a clinical genetist at KK Women's and Children's Hospital, serves as the lead principal investigator of Singapore Childhood Undiagnosed Disease and the director of SingHealth Duke NUS Institute of Precision Medicine. He is the chair of Chapter of Genomic Medicine, Academy of Medicine Singapore, and co-chair and Genetic Genomic Testing and Research Review Group. He is actively involved in research and has published in top-tier journals including the New England Journal of Medicine, Nature Genetics, Neuron, and Nature Communications. He has received multiple awards for his research, including 2015 SingHealth Outstanding Young Researcher Award, 2021 National Medical Research Council Clinical Scientist Award, and 2024 GCEO Outstanding Researcher Award. So with this record, let us listen to the presentation.
Very good afternoon. I'd like to thank the organizers for inviting me to give this talk at this momentous occasion. Firstly, I'd like to congratulate the university for its 50th anniversary, and I'd like to extend my apologies for not being able to attend in person. I do hope to interact with many of you in future events. Today, I'll talk about unlocking the future through genome sequencing and diagnosis, especially in the Asian context, which has been a focus of my lab. I'm Saumya Jamwar, a clinical geneticist based at KK Women's and Children's Hospital, and the director of SingHealth Duke NUS Institute of Precision Medicine. When we look at determinants of health, genomics accounts for about 30% of the overall impact on our health. More importantly, in individuals with rare genetic diseases, the impact is significantly higher, and these affect between 2 to 5% of all life-borns. Recent studies indicate that 5 to 10% of all cancers may have a hereditary basis, and almost all of us carry variants in genes that may affect how our body metabolizes medications, a field called pharmacogenomics. Taken together, these lead to significant social, emotional, and economic burden to the individual, the family, and the healthcare system. Over the past 2 decades, the cost of genome sequencing has declined starkly. It is now possible to do a whole genome sequence for $200 and a more high-fidelity long-read sequence for $1,000. So I'm ready to tap on the opportunity to unlock our future through genomic medicine and precision medicine. This effort is being led by Professor Patrick Tan, Senior Vice Dean Research at Duke NUS, and it has been dubbed PRECISE, or Precision Health Research Singapore. In phase 1, whole genome sequencing of 10,000 Singaporeans of diverse Asian ancestry was performed, and our work group, called the SG10K Med Work Group, analyzed the genetic risk burden of 3 significant but underrepresented Asian populations. This included looking for prevalence of genetic disorders that may affect the individual participants, looking at carrier frequencies for recessive disorders, which indicate a risk for future offsprings, and then looking at risk of drug toxicity and suboptimal dosing or pharmacogenomics. We performed a comprehensive analysis, including looking at single nucleotide variants, copy number variants, across 4,000 Mendelian disease genes plus 23 pharmacogenes. We extrapolate that findings from our cohort representing the multi-Asian ethnicities represents the greater part of Asia, which actually represents 40% of the world population. And this is where the challenge is, because there is a bias and underrepresentation of Asians in global genomic databases. So we need to build these Asian genomic databases. These are papers published previously, which showed a persistent bias initially at 4% in 2009, which improved to 19%, but that's remained consistent since then. Beyond research, these underrepresentation actually have risk for potential harm in clinical care, because variants in underrepresented populations are often misclassified, leading to inappropriate medical interventions. So in the next few slides, I'm going to share our insights from our study. The first insight: participants with a genetic disease variant. All of us carry between 3 to 4 million variants in our genome. These variants are typically benign or not disease-causing, and hence we are relatively healthy. But in about 2 to 3% of individuals, there are variants in genes that are clinically actionable. So while the individual is healthy, they may be at risk of developing a disease. These variants or genes are called secondary findings, and the American College of Medical Genetics updates the list of genes that should be considered clinically actionable. When we looked at our cohort, 3.4% of our cohort had actionable variants as per the latest ACMG secondary finding list. What was more interesting was that the distribution of these actionable variants differed across the different ethnicities. So while the overall proportion is similar across ethnicity, each ethnic group has a different disease risk. More specifically, we identified Asian-specific variants, including one in Notch3 associated with a neurological disorder among the Chinese. And while there was an increased risk associated with pancreatitis among the Chinese and Indians, it was attributed to a different gene in each of the ethnic group. The second insight, which is looking at carriers for recessive disease genes, which means what is the risk for their future offspring. All of us on average carry between 2 to 6 different variants in different recessive genes. So when we did this analysis and we looked at one of the commonest one, which was in GJB2, which is associated with hearing loss, 1 in 5 Chinese, 1 in 6 Malay was a carrier, which actually justifies our approach for performing universal newborn hearing screen to identify at-risk newborns for hearing loss so that they can be identified and managed and optimize their speech development. The second finding was identifying the variants in SLC25A13, which is associated with citrin deficiency. This is an East Asian disease. It is not well characterized and studied in the medical textbooks, but it is fairly common among the Chinese population in Singapore. It presents with neonatal jaundice, and given the high prevalence, we worked with the Academy of Medicine Singapore and College of Pediatrics and Child Health Singapore to include screening for citrin deficiency in their guidelines on evaluation and management of neonatal jaundice. We expanded and looked at genes that had a carrier frequency of more than 1 in 200, which is the American College of Medical Genetics recommendation for carrier screening. we identified 77 genes. 38 of those genes were associated with severe recessive disorders. And more importantly, 8 of these genes were not present in commercial panels. So the comprehensive carrier screen offered by commercial companies were actually not suitable for our population. Overall, we identified 0.4% of all pregnancies to be at risk of having a child with severe genetic disease. The third insight was looking at pharmacogenomics, and as mentioned earlier, 99.7% of our participants carry a pharmacogenomics variant. Just because they have not received that medication, they have not had an adverse event. But 51 to 77% of our participants carry a variant in CYP2C19, which is associated with clopidogrel metabolism. In Singapore, about 10,000 patients are prescribed clopidogrel annually, which means that half to three-quarters of these individuals are probably not receiving the appropriate dose, putting them at risk of developing a second stroke or a second cardiac event. We then looked at variants that are associated with life-threatening side effects, and 26.8% of our participants carried such a variant. 25.6% was in a variant in HLA, and this is associated with toxicity with carbamazepine. And this actually is something that is already implemented in Singapore's clinical guidelines, where the Health Sciences Authority, which is the FDA equivalent, has mandated that carbamazepine should not be prescribed prior to return of HLA-B1502 test results. So all patients who need to prescribe carbamazepine need to be tested for HLA-B1502. The last group that we looked at was those individuals who were identified as a 3.4% of being at risk of a genetic disease, and how many of them actually carried a pharmacogenomic variant. Surprisingly, it was 1 in 4 individuals. 14 out of the 61 at risk of cancer would have poor response to chemotherapy and would need adjustment to their chemotherapeutic regime. In a separate study, 8.1% of admissions to one of our tertiary hospitals, Singapore General Hospital, was related to adverse drug reaction. So drug reactions in toxicity, inadequate dosing are a significant cause for concern in managing our patients. And this allows us to actually actively look out for them and manage them more effectively. So what do we do next? We looked at translation. So the first translation that we looked for was participants with a genetic disease variant. PRECISE is currently in phase 2, where they have ongoing clinical implementation pilots to see how they can identify individuals with familial hypercholesterolemia and hereditary breast and ovarian cancer. My group is leading the second translational project, which is return of these actionable genetic findings, identifying these individuals, be calling them back for genetic counseling, returning the results, and then recommending follow-up with the relevant subspecialist. Our group also looked at resource utilization by use of genome sequencing, specifically in pediatric genetic diseases. And we created 5 different models. This was work done in collaboration with Prof. Nick Grace from Duke NUS. And we identified a mean savings of an average of $5,000 to $6,000 per patient if whole exome sequencing was used as a first-line test. The second translation was looking at carriers of recessive disease genes. In Singapore, universal carrier screening for thalassemia was introduced in 1992. Over 70,000 participants have been registered, and it has led to a dramatic reduction in the incidence of thalassemia major. The orange line indicates the anticipated numbers, which is between 7 to 9 patients per year. But with the setup of NTR, the numbers have dropped to between 0 to 1. Because this is not mandatory, we counsel the couples, and if they decide to continue with the pregnancy, we still manage the pregnancy and offer them appropriate medical care. But this is now, with this beyond thalassemia, there are other common recessive diseases. One such example is spinal muscular atrophy, where the treatment cost is $3 million per patient. Based on the carrier frequency, we assume between 1 to 3 cases of SMA per year, which means that the cumulative cost is going to balloon in the coming years beyond $30 million. So the question was, can we develop an expanded carrier screening panel but customize it for the Singaporean population? This is what we did through collaboration with our partners at DXT Hub and Precise, where we have developed a customized carrier screening panel and have received funding to actually implement it across 39,000 couples in the public healthcare institutions in Singapore. We are hoping to start that program very soon, and I'm happy to share. I'll be happy to share the findings in future meetings. The third translation was integrating pharmacogenomics into clinical care. And again, this is a busy slide, but essentially what it shows is that if we can identify an individual who is at risk for the drug that's being prescribed, we can intervene before they develop the side effects or before they have suboptimal dosing. So in the end result is a personalized prescription based on their pharmacogenomic data. While these are great, there are potential barriers, and one such barrier is a variant of uncertain significance. So while I mentioned that we all have variants, the variants can be classified as disease-causing or not disease-causing. But there isn't enough data to classify a category of variants, which we call variants of uncertain significance. These variants of uncertain significance, or VUS, exist in a continuum. Some of them could be classified as disease-causing or pathogenic. If we include such variants, our frequency of carriers of actual variant goes up from 3.4 to 5.2%. In a study that was published last year by our group, we looked at 1.6 million individuals who had undergone genetic testing, and we identified that Asians were at higher risk of finding a VUS when they undergo genetic testing. So the question this leads to is, are we underdiagnosing our patients? So while we can identify some, we may be missing some as well. The second barrier is genetic discrimination or non-discrimination. So while many countries have laws that protect individuals from discrimination based on genetic results, Singapore did not have such law. We worked with the Ministry of Health, and in 2021, a moratorium was issued to protect individuals from discrimination by insurance and employers. This has helped to recruit participants for genomic research and has helped address concern for secondary findings. However, the moratorium does not cover those with existing medical illness, those diagnosed on newborn screening, or prenatal testing. So can we do more to protect those with genetic diseases? And this is an ongoing conversation with the Ministry of Health in Singapore. The last barrier is the number of skilled personnel in genomic medicine. Understanding that there is this gap, we worked with Duke NUS to develop an executive certificate program in clinical genomics. It's a 5-day work program that is a stackable module to a master's program. We've also offered a genetics education for healthcare professionals, which is a 4-hour workshop, which is conducted online as well as in person, which is aimed at other healthcare professionals like allied health, lab professionals who want to just understand a bit more about genetics. And more recently, we decided to focus on the biggest workforce in healthcare, which is nursing, and set up a global nursing network for rare and undiagnosed diseases. This is a network that aims to teach and educate and connect nurses who may encounter a patient with genetic disease. They don't have to be genetic nurses, but they just need to be someone who takes care of patients. And because in many parts of the world, nurses are the only healthcare professional a patient may see, empowering the nurses through this network allows us to identify and manage our patients better. So a brief advertorial, if you have any nurses who are interested, please ask them to sign up and join the network. With that, I just want to conclude. In the SG10K MED, the key findings, we had 3.4% of participants at risk of actionable genetic diseases, 0.4% of all pregnancies at risk of severe recessive disease, 99.7% carry a clinical significant PGX variant. There are ongoing translational projects, but there remain barriers to successful implementation. Just want to acknowledge the work that was done. It wasn't just my work, it was a work done by a big team and received funding from multiple sources. So just want to thank all of them. And if anyone's interested, the paper was published in Nature Communications in November 2022. With that, I'd like to thank you for your time and attention. If my email is there, if you have any questions, feel free to drop me a note and I'm happy to continue the conversation. Once again, congratulations and thank you for the kind invite.